good to be here. I hope to start out, if my slides come up, with just a bit of reminiscent. First of all, I really appreciate Kobe Ramon and the group from Comtech, and of course Lori, putting this together. This has really been an amazing, who would have thought several months ago that we'd have a room full here and pretty much room next door. So if I can have my slides that I delivered to you early this morning. Is this a plot of yours, Lori?
I had to take every advantage that I could.
There we go. Perfect. Thank you. Well, I thought I would reminisce just a little bit, taking the, just to get away from the subject, because that's going to be an easy sell. This is my first trip to this wonderful land. Probably many of you couldn't tell who this was up there, some rock star. And actually, this was the first group. What a difference from today. This was a group that I helped bring here. You'll see Andy Novick in the middle. Couple of repeaters, not many, but this was many, many years ago. Stan Brosman and Michael Brower's there, etc. We had an amazing time, and it took a long time to get going again. Here we are in Jerusalem. Here's Lori and I with Jacob Kennedy down in the south. In Beersheba, Lori's kind of lost in the midst of dancing. As always, we're going to test you out during this meeting. See, Lori, if you've improved. My first fellow who I had the opportunity of learning about this country was Aaron Luria. This is for many of the Israelis in here who remember him. He's passed on, but he came to Cleveland, Ohio, and worked with myself and my much older resident cohort, Scott McDougall and Bob Flanagan, working together, and Jean DeKernian. So we learned a lot about this country. My next and first fellow in Memphis, to your left, is Israel Nissenkorn, who's since retired. He came to Memphis, Tennessee, and I remember he always brought a map with him because, of course, Israel is always, everybody thinks Israel is this country the size of China from the CNN and Fox News, etc. So he always had a little map to show that Israel is this tiny little country in the Middle East. Here he is working. Those of you who know him now, he's changed just a little bit. Chaim Matzkin, who I understand, he's one of the chairmen here in Tel Aviv. It just became head of your board. Chaim came to Memphis and then joined me in Miami, and he has the record. In 2 years with me, he wrote over 21 papers in peer-reviewed publications. Here we are. My first Bedouin meeting, unfortunately, was Pesach, so I couldn't eat anything and I had to explain to them. But thanks to Dr. Kennedy, I had the opportunity of sitting in one of the tents. That was a great time. Andre Newlander, another fellow who's now chairman, taken over from Dr. Kennedy down in Beersheba. And again, just a thanks to Kobe Ramon, who's done a lot of work in putting this together, and I think hats off to him. And here's another group from one of my many visits here. So, Lori, this is the most important slide. You have an obligation to the patient. So really, when you take on active surveillance, all of us are committed to our patients. You don't want a single one of those patients to die of prostate cancer because, again, as highlighted earlier, that is their concern. Clearly, I'm with you, Lori, on active surveillance, and I'll show you I'm a big believer in it, but we all know of this important facts. Clearly, we want to cure every man that we start on with active surveillance. And clearly, the morbidity of a total prostatectomy or radiation therapy is dramatically underestimated in our literature. And I think the main issue, as indicated earlier, is really about ED. And that's a primary problem for many men. Now, clearly active surveillance requires patient understanding. That takes a long time. Laura, you're going to have to go through the difference between Gleason 3 and 4. Actually, you sold the argument in your very first slides. You indicated that, yes, a few of the people with Gleason grade 4 die of prostate cancer. That's a major issue as soon as you acknowledge that. Clearly, they want to avoid the side effects of treatment, and the patient must know that there is a small possibility they'll miss the opportunity for cure. We're all aware of the Epstein criteria. The key thing that I personally don't like is no more than 50% of one core. In our center, that's a little bit too high. And in Miami, in my personal cohort, I don't accept a patient who has more than 20% in any one biopsy. And of course, obviously, Gleason 6. Here are just a few of the centers. The criteria used basically is pretty much the same, with the exception of how much you accept per core. But notice that almost all of them, Lori, and even now you said in your center, accepts only Gleason 3+3. Again, you have the possibility that you just haven't found the 4 with your biopsy. We require at this time, and maybe this will go by the wayside with some of the things we heard today, is that we require yearly biopsies. Obviously, after 2 or 3 years, the patient's PSA is still 1.1, hasn't changed at all. Of course, we relax that to every 2 or 3 years potentially. But we try to stick the opportunity for every year doing a biopsy. Our decision to treat is any grade 4 or increase in volume. And we've had a couple of publications, just those of you who are interested, our first in 2010, and then in 2012, a more recent publication looking at the patients who went on to have a prostatectomy. Journal of Urology in 2012, we've continued to learn from what we have gained in the active surveillance with a cohort of approximately 300 patients. Though this is our most recent data, we're updating again, 276 patients, at least 1 surveillance biopsy, median follow-up over 3 years, and this is pretty standard. Approximately 25 to 30% in almost every one of the studies I mentioned, Hopkins, UCSF, Lori Klotz's data, if you exclude the Gleason grade 4s, 1 in 30 patients will eventually go on to have treatment. But that means that 75% do not need treatment, and all of these studies are maturing, and that number has plateaued, and I think that's a very important aspect. Progression in active surveillance, again, shows that we have pretty much stabilized. Of course, you're going to go up over time, but stabilizing at about 25%. Just one caveat that I hope other people have more numbers we can put together. We're a little concerned that if you separate out the Afro-Americans, that they progress at a higher rate, almost approaching 50%. And we've published that information, but we need many others who have a larger cohort of Afro-Americans. Maybe there's something there that we should be a little bit more cautious in putting Afro-Americans on active surveillance. Just something to think about. And this is a slide showing the difference between Caucasians in the blue above and the Afro-Americans in the red. And that's pretty worrisome. We have not yet started to tell patients about this, but we need further support in looking at that caveat. Of the patients who have gone on to treatment, it's about 50-50 surgery, and our cohort who went on to surgery, I won't go through all the details. It's similar to a regular radical prostatectomy de novo database. 3 patients who we've operated on or I've operated on have biochemical recurrence, all of which have been salvaged with radiation therapy. So importantly, with the criteria of only 3+3, no more than 20%, no patient has died of prostate cancer. Some of these patients are now 10, 12 years. None have metastatic disease, not a single one. None have clinical evidence of prostate cancer outside of the prostate. And just to show you a couple typical patients, here we are, a gentleman, Gleason 6, PSA slowly rising. As soon as he got to 7, we said you should have your prostate removed. He agreed, and his PSA undetectable. Now, here is an exception, starting out, however, with a Gleason 6. Now, he started out at 78 years old. Radiation would have been a very good option for him. He's perfectly fit. He eventually went on to have a Gleason 7 and elected to stay on active surveillance. So this is not someone beginning, however, with a Gleason 7. He's now 83 years old, still on active surveillance. One of the questions that comes up, what do you do with someone on testosterone? That's food for another discussion. At any rate, we've continued the patients, kept them on testosterone as long as they didn't go over their normal level of testosterone. We think it is reasonable to put a patient on active surveillance who has a low testosterone, to give him exogenous testosterone to allow him to have a normal testosterone level. Now, here's the key. The available information about active surveillance results on patients with intermediate risk really is minimal. And Lori also already gave that information. I would say it's minimal, and I think he would probably agree. However, if we look outside of active surveillance, what about intermediate risk? And this has already been indicated, some of the long-range studies on patients in intermediate risk, there is a significant, and again, I think we're striving here for zero metastatic disease, zero deaths. That's our goal in active surveillance, and I think Lori would probably agree that's certainly our goal because you're starting out with no treatment. And if you look at intermediate risk, there are some patients who die of prostate cancer. I won't go through all of this data, but it's in much of this long-term information, cause-specific survival. If you look at the higher grades, some patients do progress and die of prostate cancer. Here you see it here, difference by grade. Again, another study, again, we're looking at long-term data, which is critical in prostate cancer. When you start taking people with Gleason grade 4, under the watch for waiting initial, some of these people will progress and die of prostate cancer. And again, these tend to be with some degree of grade 4. Now, yes, Dr. Srigley says we're going to be changing our Gleason criteria, but currently we have to go with the information we have. As soon as you get to 7, the hazard ratio of the relative risk dramatically goes up. It doubles. Is that fair for our patients to put them on active surveillance with our current information? Most of us are not using regular MRIs for biopsying of patients. We have not. We certainly will get into it, but currently I don't think we can make that leap of faith. Again, more information on patients with Gleason 7, and I'm just repeating over and over again that there is a difference in their prostate cancer-specific mortality compared to a 6. Again, more of the same data. As soon as you hit 7, then the prognosis gets a little bit worse, and I don't think that's fair for our patients currently. And here you see that information highlighted once again. Over and over, the same data from our long-term outlook on patients once they hit a Gleason 7, being quite repetitious here. So compared to patients with biopsy Gleason 6 or less, it's almost only 6 now, with a patient who has a 7, there's a significantly higher risk of dying from prostate cancer, both with and without treatment with curative intent. Yes, these are large populations of patients. Some started on watchful waiting. Patients with Gleason 3+4 and certainly 4+3 were not separated in many of these studies, and I'll grant Lori that information, and this may be evolving. The acceptable level of risk is not known. That is our key problem. And the onus is on the physician, you the urologist, to minimize the risk of progression once you make this contract with a patient to enter into active surveillance. So I would hold at this time, with our information to date, when someone has grade 4, and we don't have this very sophisticated genetic information, we don't have MRI serially on people, that we should not enter them into active surveillance without maybe the express information for the patient, different comorbidities, et cetera. But for the healthy gentleman who's 50 to 75 years old, who they could be likely cured by treatment, to put them in active surveillance is not something I'm willing to accept at this time. Again, thank you.